Good evening, everyone. Hello, and welcome to yet a next episode, fourth one in the iTalks web series. And today, again, we unite on this unique platform to discuss a topic related to anemia. And just like the other topics which we've discussed so far, this today's session is going to be equally important and very exciting as well. So we're going to discuss on anemia and kidney disease. So before we kick off today's session, let me just introduce you all to our very own Dr. Sanjay Kalra. Sir is a NDM endo and from Karnal. He's a board member for International Society of Endocrinology. Dr. Sanjay Kalra is a president for Indian Professional Association of Transgender Health. Dr. Sanjay Kalra is a president-elect for South Asian Federation of Endocrine Societies. He is a past president for Endocrine Society of India. Dr. Sanjay Kalra has been practicing at Bharati Hospital and Bride at Karnal, where he can be reached and connected to. So, good evening, sir, and welcome to the fourth session of Iron Talks. How are you, sir?
All fine, Karan. Thank you. I'm feeling as strong as I am.
Great, sir. That's wonderful to hear. And as always, we are pleased to have you on this platform. And I I I release the platform to you, sir. The stage is all yours.
Thank you, Karan, and thank you everybody for logging in. Sunday nights are times when you can do anything you want. Uh, and there are 33 crore things that can be done at any given point of time. And for many people, maybe studying, learning about iron, learning about healthcare, that might be at 33 crore rank. But all of us who are logged in here today share one thing in common. And that is that we actually want better health. We want better health for our countrymen and women, for our fellow citizens. And this is an attribute that is shared by our speaker. So for me, it's a matter of great happiness to be able to present to you one of the best teachers in the entire country. Madam is Professor Manisha Sahai. Warm welcome, Madam. Madam is Professor and Head of the Department of Endocrinology at the prestigious Osmania Medical College in Hyderabad. She is the Deputy Chair of the CME Committee of the International Society of Nephrology. So she keeps the Indian flag flying high at the global level. She is also Vice President of Women in Nephrology. And the list of prizes, the list of accolades that she has it would fill an entire book of its own, a full monograph. She is Editor-in-Chief of the Indian Journal of Transplantation and also the Indian Journal of Hemodialysis. So, warm welcome, Dr. Manisha. Today, you have in the audience doctors from various walks of life, MBBS, MD Medicine, MD Gynae, all other specialties put together, and from the entire country and beyond as well, from the neighboring countries. So, ma'am, before we begin, you're from Osmania Medical College. Why is
Yes.
Osmania famous? What is it in history that Osmania did for India?
See, Usmania is one of the oldest medical colleges in India. And apart from that, you must have heard about chloroform commission and all that. So that was presented to the world by Usmania. And one of the first lady doctors in the country was from Usmania. So the college has around 250 undergraduate seats, and it is one of the biggest medical colleges. Can you guess how many beds does Usmania have? Usmania Medical College has 5,500 beds. So I'm pretty sure these many number of beds are not there anywhere in India. And I think it's the second largest hospital as far as the bed capacity is concerned. The daily OP footfall of patients is around 7,000. So you can just imagine how large the college is. And it has 10 affiliated colleges. So each unit is a hospital by itself. So you have a gynec hospital, an ENT hospital, an eye hospital, and whatnot, an oncology center, and it is governed by Usmania Medical College. So it's one of the oldest and one of the prestigious colleges in the country.
And chloroform was anesthesia that was actually developed and polished in Osmania in Hyderabad. And then the team of students and anesthesiologists went from Hyderabad, Deccan, all the
Absolutely.
way to London to teach them how to use chloroform as an anesthetic.
Yeah. So something we should be proud about. Yeah.
Professor Manisha, hello to you from Pakistan, from Rabia Umair ji. and from India as well, from Parul Pai and from Mahbud Ali, and lots of other people will keep on joining. And there'll be lots and lots of questions. So we are in this series of iron talks. Iron is related with the kidney as well. And Madam will be speaking to us about the iron, a renal perspective. But feel free to shoot your questions, ask her anything you want to about anemia. I have no hesitation in saying that there are 2 or 3 people in the country whom I have learned anemia from, and one of them is Dr. Manisha Sai. So, Madam, thank you for mentoring us as well, and all of us now, mentees from across Pakistan and India, we look forward to listening to you. The stage is yours, please.
So Dr. Sanjay Kalra has this unique distinction that he is very humble and he keeps on praising everyone to the skies. In fact, he is the person whom many of us look up to. So wonderful work, Dr. Kalra, and I mean, it's really our proud privilege to be associated with you. So shall I start my talk?
Yes, please.
Right. Okay. So my screen is visible, I think. Yeah. So I have named it as Keeping It Red, Anemia in Chronic Kidney Disease. And we'll be talking about how to manage that. So we all know, let me start with simple thing. What is anemia? So anemia is defined as a hemoglobin less than 13 gram per deciliter in males and less than 12 gram per deciliter in females. So just remember that. And we have varying definitions depending on the age. But remember 13 and 12. There are multiple anemia guidelines, and starting from 2000 onwards, CKD anemia has been defined variably in different guidelines. In fact, we still don't have a consensus on the definition of anemia. The latest meeting was held in 2019. And you can see most of them now have settled on hemoglobin less than 11 as per the NICE guidelines. KDIGO says less than 12 and 13 in males. And the European guidelines, they again say less than 12 and 13. So 2015 has said in a CKD patient less than 11. So as you can see, there is some disparity between the guidelines also. Now, before I tell you about anemia in CKD, we all know what CKD is, but for the benefit of postgraduates or MBBS students who've joined, chronic kidney disease stands for impairment of kidney function for equal to or more than 3 months. So don't label anybody coming for the first time with creatinine high as CKD. It's for 3 or more than 3 months, and it is defined by either fall in GFR, where you can have an elevation of creatinine as well, and or presence of urine albumin. So any of them, if they are persistent for more than 3 months or equal to 3 months, you can call that patient as having CKD. And we all know that I talked about GFR. So as smart doctors, we should all know that creatinine you easily can get from the lab and how to convert it into GFR, and you have these smart apps on your phone. And one message of this webinar, though it's on anemia, is that you will learn to treat anemia if you learn to understand what CKD is. CKD is very frequently missed because many of the times creatinine is normal, and unless you do the GFR, you will never find out how much really the kidney function is. Even with the creatinine of 1.2, the GFR may be low. So this is how you calculate it. So before I embark on my discussion on anemia, you should know what we are talking about when we are talking about CKD. So just after the talk is over, you can download this free app, the National Kidney Foundation calculator, GFR calculator. And now there is an advancement on that. Now even race also is not required. So just age, creatinine you fill, and you get the GFR. So depending on the GFR and the urine protein or albumin, you have different stages. So G1, G2, so on and so forth till G5. G5 is the worst, where the kidney function or GFR is less than 13. And A1, A2, A3 is increasing severity of albuminuria. So A1 is less than 30, whereas A3 is more than 300 milligram per day of albumin. So remember, normal protein in urine is 150 milligram and albumin in urine in 24 hours is 30 milligram. So this is based on GFR and albumin. So these are only 2 slides telling you what CKD is, chronic kidney disease. And now we come to the topic at hand, anemia in chronic kidney disease. So you can see that anemia develops very early in chronic kidney disease. Stage 1 itself, you have around 10% of people having anemia. And as you progress towards stage 5, almost 50% of people develop anemia. So CKD anemia progresses as the disease advances. When should you screen for anemia? So all CKD patients, at least once in a year. if they are in CKD3, which means GFR above 30. And in case the GFR goes below 30, you have to screen twice. It's easy to screen for anemia. Just do a hemoglobin. Even if you do it once in 3 months, that is okay, which most of us do. But guidelines say even once in a year is okay in early CKD and twice in a year for late CKD. And we should investigate for the cause of anemia if the hemoglobin is less than 11 or if the patients have symptoms. So these are some basic guidelines. Fine. Now, what causes anemia? So we have understood what anemia is, and we have understood that CKD anemia is very common. What causes anemia? So for this, we know that the normal erythropoiesis starts from the hematopoietic stem cell, and slowly it progresses and ends in the formation of erythrocytes. The early part of erythropoiesis is dependent on erythropoietin. The latter part is dependent on iron, B12, folate, etc. So remember this figure. Both iron and erythropoietin are pillars for erythropoiesis, and deficiency of either of them can lead to severe anemia. Now coming to iron deficiency, the talk of the day, the iron talk. And then later on, we'll talk something about the erythropoietin deficiency. And the concept of anemia is changing. That I'll discuss in the last part of my talk. So iron deficiency, we all understand. Word very simple, we think deficiency of iron in the body. But remember, it's not that simple. Iron deficiency can be absolute iron deficiency or functional iron deficiency. Absolute iron deficiency means that there is no iron in the body. Whereas functional iron deficiency means iron is there in the body, but it is not being utilized for formation of RBC. So let us see why that happens. Coming to absolute iron deficiency, very easy, poor intake. We are not taking iron in the diet because of poor appetite, poor iron absorption in gastrointestinal tract, because of many drugs which the CKD patients take, phosphate binders, PPIs. So all these things, they cause decreased intake of iron. The iron doesn't enter into the body. Then whatever iron enters into the body gets lost in CKD patients, especially if they are on dialysis also, because of blood losses from gastrointestinal tract, because the patients are on anticoagulants, antiplatelets, etc., and because of repeated blood samplings. So it's very important that these patients, we should know and identify iron deficiency because they are very prone to iron deficiency. And see this slide. How much is the daily blood loss in healthy patient? It's not even 1 ml per day. But look at the hemodialysis patient, it's 5 ml per day, which translates into 5 liters per year. Can you imagine that? And annual iron loss in a dialysis patient is 5 grams per year. A huge amount of iron is lost. So it's very clear that many of these patients will have absolute iron deficiency. Either they are not absorbing iron, or if they are absorbing iron, they are losing iron as well. Now, most important thing which people don't understand is functional iron deficiency, where the iron stores in body are good, but all the iron is stored inside the cell. It's not available in the blood, and as a result, it does not go to the bone marrow for erythropoiesis. Why this happens? We all know whatever iron we take, it enters the gastrointestinal tract, then it gets absorbed from the gastrointestinal tract, and here you have a protein called ferroportin, which helps in transferring the iron from gastrointestinal tract into the blood. Once the iron comes into the blood, it's bound to transferrin. And from this transferrin, it's transported to the bone marrow for erythropoiesis, 75%, and remaining 20% goes to the stores as ferritin. So you can see the green cell there, which shows the stored iron in the form of ferritin. Now this ferritin comes out in the blood through ferroportin, and then it becomes available for RBC formation. So we have understood this ferroportin is very, very important. It is the key, and the intracellular iron is under lock inside the cells, and without the ferroportin, this iron, howsoever much is there in the cell, will not be available for erythropoiesis. In CKD, what happens? In kidney disease, what happens? There is a molecule called hepcidin. It is a protein which is produced by the liver. It is a marker of inflammation also, and this hepcidin is the culprit. It suppresses the ferroportin. So as a result, the iron keeps on getting stored inside the cell, and it is not available for RBC formation. So this slide we should remember. It's very, very important. So as I said, hepcidin locks the iron inside the cell. It's a lock, and the key is the ferroportin. So this results in functional iron deficiency in CKD because iron is there. Whatever iron is there, it's locked inside the cell. So now, why CKD causes anemia? It's very clear that it's because of iron deficiency, which may be absolute iron deficiency as well as functional iron deficiency. Also, CKD impairs the erythropoietin synthesis. Also, CKD may be responsible for hemolysis as well. So CKD disturbs all phases of erythropoiesis. Now, how to evaluate for anemia? So obviously, we have some tests, and these are the tests which we do. Hemoglobin concentration, we all know. RBC indices, reticulocyte count. Now, very important tests are iron stores, which are frequently not done. CBP, everybody does. But what everybody does not do is iron stores. Iron stores we look at by doing serum ferritin. And the other thing is, as I said, iron stores may be there, but how much iron is being supplied for erythropoiesis? This is reflected by TSAT. TSAT is transferrin saturation. So these two are very important. The other tests, mostly all the physicians do B12 levels. They look for hemolysis. They check for electrophoresis if required, bone marrow, assessment of GI losses. So most of these tests are done. But what is generally forgotten is the iron stores and iron supply for erythropoiesis. So what you need to ask the lab is to do an iron profile, serum iron profile. And how do we find out whether it is absolute iron deficiency or functional iron deficiency? Remember, what happens in absolute iron deficiency? The iron stores also are low. So what you will have a low ferritin, which reflects iron stores, and you will have a low transferrin saturation. So normal transferrin saturation is more than 20, but in absolute iron deficiency, both will be low. Stores will be low, and there will not be any iron available for erythropoiesis. Available iron we test by looking at TSAT. TSAT is saturation. And TSAT is calculated by serum iron by TIBC, but do not break your head about it. Most of the labs give TSAT. So ask for ferritin and TSAT. Both are low, it's absolute iron deficiency. Or if the ferritin is high, meaning stores are high, but TSAT is low, it is functional iron deficiency. So very simple. You can identify iron deficiency by looking at ferritin and TSAT. This concept should be very, very clear for evaluation of anemia in CKD. Never ever miss functional iron deficiency. If you only look at ferritin level, you'll be very happy. Ferritin is very high. People think stores are high. But unfortunately, there is no available iron. So check for TSAT and ferritin. We all know how, suppose we have demonstrated iron deficiency, how do we treat it? The formula is simple. Total amount of iron is desired hemoglobin minus actual hemoglobin into weight into 2.5 plus iron stores, iron depot. So iron depot roughly we generally take as 500 mg. So it's easy to calculate the iron deficiency. So generally, roughly we say in a year, a person requires maybe 2-3 months around 1000 mg of iron, but you can accurately calculate it from the formula. So you find you have calculated by formula, you have arrived at a certain figure. Now, which iron should you give? There are so many iron preparations. Oral iron is there, IV iron is there, what you should give. So oral iron preparations, we have many of them: ferrous gluconate, sulfate, fumarate, carbonate, glycinate, ascorbate, and succinate. So many of them are there available in Indian market. Commonly, we ask the postgraduates, the elemental iron, how much percentage of iron is there in each of these preparations. So it's important to understand. We all use Phe, Fol, this, Fol, that, Fol, or some form of iron, but you should always know what is there in that iron. Try to read what's there. So best iron available in Indian market is ferrous fumarate. It's 33%. The other ones, succinate and carbonate, are not available that freely. Ferrous fumarate is available freely. It's 33% of elemental iron, and it has a very good absorption as well. So 100% absorption if you compare it with sulfate. So it's a good absorption. So among the oral iron preparations, these ferrous fumarate is the best, but most of the government hospitals have ferrous sulfate. Gluconate and all have very less elemental iron. Ascorbate, gluconate are not very good sources. So this was available in India. They are all very commonly available. Now there are some challenges with these oral iron preparations. Main thing is the GI side effects. So now we have some new iron preparations as well. Remember that new iron preparations, they are more GI friendly. They are chelated, they are organic, they are acid resistant, they do not interact with phytate in chapatis in the wheat, and many of them bypass the iron transporters. So the newer iron preparations are a little bit gastro-friendly, but that doesn't mean you cannot use the fumarate and all. They are also quite okay. But newer molecules are being available now, and we should know about that. So we have ferric pyrophosphate, carbonyl iron, ferric citrate, liposomal iron, sucrose somial iron polymaltose, ferric maltol. So all of these are now available in Indian market, and they are, however, very costly. The advantage is minimal, so I would recommend using them if the person is really intolerant to ferrous fumarate. Otherwise, ferrous fumarate can be used for most of your CKD patients. Fine. But do you think oral iron is enough? Many trials have shown that in CKD patients, IV iron is little bit better than the oral iron. So there were certain studies which have shown that IV iron has a better bioavailability, directly goes into the circulation, and especially in those patients who are IV intolerant. Now, IV iron preparations, what do we have? In the yesteryears, we used to have iron dextran, and we were scared of these injections because test dose was required. Anaphylaxis was very common. Iron dextran can be used in pre-dialysis patients. You can put them in the hospital, give the dextran, and then send them back. But it needs a long infusion time. You have to put the patient for 6 hours in the hospital. You have to give it under observation. In dialysis patients, it's simple. You can give it on dialysis. But nowadays, nobody uses iron dextran because you have better preparations available. One such commonly used preparation in India is iron sucrose. So iron sucrose can also be given in patients by physicians, those who see pre-dialysis patients in their clinics. So here it can be given on dialysis as well. The important thing is test dose is not required. Anaphylaxis is not common. But only thing is that you cannot give, I told you roughly at a go, the patient needs 1000 mg most of the times. So this you cannot give 1000 mg of iron sucrose at a go. You have to split it in different doses. Safe is to give 200 milligram at one go. So you have to call the patient 3 times, 4 times, 5 times. If you want to give 1000 mg, you have to call the patient 5 times. So you have to give it, you can give it over 30 minutes. So this you can do in your clinics, in your hospital, but it should be given in a supervised manner. In dialysis, we give easily during dialysis. At the end of dialysis, we give iron sucrose, and it's very commonly available, cheap and effective. There are newer iron preparations here as well. On all should know, be it gynec or nephro or endo or a physician or MBBS, because treatment of anemia is basic. Everybody needs to do it. And the other preparation available, FCM or ferric carboxymaltose, it's really good. Again, no test dose, no anaphylaxis, can be given in your clinic. The patients who are not on dialysis, those patients also, and the advantage here is you can give 1000 mg at a go. So that's important, but you have to give it over 15 minutes. Dialysis, it's easy. We give it on dialysis as well. Iron isomaltoside is also available, but pre-dialysis, it's not having many studies. Dialysis patients, we use it. And ferromoxetol can be used, but it's not available freely as of now. But remember these 3 names: FCM, isomaltoside, ferromoxetol. Especially for postgraduates, these are going to be asked because we take iron therapy lightly. We do not read the tablet, what's written on that. We do not read what's little on the injection. We just give IV iron. All iron preparations are slightly different, and you need to know it. And this is one of the favorite questions of the examiner, not only for the examiner, for the patient. If I ask my postgraduates, they daily write IFA and all those things in their prescriptions. But if you ask them how much elemental iron was there in that, I have not received a satisfactory answer from many of them. So it's important that we should know what we are giving to the patient. And as I said, oral or IV iron, which one? For patients which are seen by physicians, pre-dialysis patients, you can give oral iron. However, most of the hemodialysis patients require IV iron. In case oral iron is not working or the patient is intolerant to oral iron, you can give IV iron. And as I said, you can give iron sucrose also. You can give ferric carboxymaltose also. But Never advise iron injections at home. Never ever do that. It should be done, monitored in your clinic or hospital with the anaphylactic preparations at hand. The newer irons do not cause anaphylaxis, but it's better to be safe than sorry later on. Now, previously, how much ferritin should we aim for? We used to say about 500 is the limit and do not exceed ferritin above 500. So most of the guidelines said 500, but then we had recently this pivotal trial, and this in 2019. And with this, it showed that if you increase the ferritin level target to 700, it's even better. And similarly, after this, there was another trial, the Drive and Drive 2 trial. This study also said that ferritin threshold up to 800 can also be adopted. So now most of the guidelines are moving towards giving IV iron as high as 800 of ferritin. Previously, we used to stop at 500. So that is important. Now again, as I said, you can see the guidelines. So most of the previous guidelines said 500, but now it's more than 800, or at least 800, not more than 800, 800. So these were the previous guidelines, but the UK Renal Association has changed its guidelines to 800. So remember, ferritin, you can go up to 800, and transferrin saturation about 30. Fine. So I've told you when to give iron. I should also tell you when not to give iron. So Dr. Sanjay jokingly said he feels like an Iron Man, but it's not good to feel like an Iron Man, because Iron Man may have so many problems: pituitary problems, thyroid problems, heart, liver, pancreas, and gonads. Iron gets deposited in all these tissues, and this is what we call hemosiderosis. This differs from hemochromatosis. Hemochromatosis is genetic, whereas hemosiderosis is acquired. And here the iron gets deposited in the reticular endothelial system, whereas in hemochromatosis, the iron gets deposited in the parenchymal cells. And this hemosiderosis, how do we pick it? By abnormality in liver function tests, and sometimes MRI of the liver picks up altered echo texture, and liver biopsy, again, you have high stores of iron. So iron is to be taken in appropriate dose. Do not overdo it, neither underdo it. You should give the right dose for the right patient. Fine. So we have made the patient iron replete. The patient's TSAT is now 30%, and ferritin has gone up to 800. Still, hemoglobin has not reached the target of 11.5. What else can we do? You can use ESAs. ESA means erythropoietin stimulating agents. So what should be the target of erythropoietin therapy? Again, in a CKD patient, never aim for hemoglobin of 13 or 14. Always be near 12. That's between 10 to 12. And this is what all the guidelines say: maintain hemoglobin 10 to 12. You can start ESA therapy if the hemoglobin falls less than 10 and continue it till the hemoglobin goes to 12. But after that, stop ESA therapy. ESAs are of different types. Erythropoietin, which we all know, they are short acting, and you give around 50 units kg per dose 3 times a week. They are moderately long acting, that is darbepoetin alpha, which is given roughly once in a week or once in 2 weeks. And then you have SERA. SERA is continuous erythropoietin receptor activator. All are available in Indian market, and the monthly cost of all is same. So if you give SERA, you have to give to the patient maybe once in a month. Some people prefer that. Some people go for shorter acting erythropoietin. You can use, all are equivalent. And the route of use can either be subcutaneous or intravenous. So those patients who are not still on dialysis, use them subcutaneously. Those on dialysis, you can give intravenous. Subcutaneous has an advantage that the half-life is longer. Fine. So very easy. Iron is available. ESA is available. But everything is not so rosy. There are certain problems with ESA. What are those problems? One thing is, it's an injection. People shy away from injections, especially pre-dialysis patients. They are not willing to take injections. The other important problem is, if you go overboard and correct the hemoglobin beyond 12, it causes harms. For example, strokes, MI, because it makes the blood viscous. There is high tendency of thrombosis. There is hypertension, sometimes a risk of malignancy, pure red cell aplasia. So these are some side effects of erythropoietin. So too much of any good thing is bad. And 4 large trials have examined the efficacy and safety of ESA: normal hematocrit trial, COI trial, CREATE trial, and TREAT trial. And they compared 2 groups of patients, those with hemoglobin 11 and those with hemoglobin 13. And all patients with hemoglobin 13 had high risk of cardiovascular deaths. So it's important that we should not overdose ESA, be satisfied with a hemoglobin of 11.5. So what used to happen is, in India, we never reached the target of 13, because in the earlier times when we were students, we were taught by all guidelines, maintain a target of 13. So Western world used to maintain a target of 13, whereas Indians used to maintain a target of 10 or 11 because we couldn't afford ESA. And the funny part was, our patients did much better than the Western patients. And later on, after so many studies, some of the studies from India, it was realized that what Indians were doing was good, and the target was brought down to 11.5 by Western guidelines as well. So in India, we did not have that many problems because we never reached the target of 13. So it's a common thing which the patients ask, because on the lab reports, it's always written hemoglobin 14, 13. And CKD patients, they keep on taking ESA because they say, no, ma'am, our hemoglobin is 11. So we have continued taking it. So we have to specifically tell them the lab report targets are for normal people, not for CKD. For you, the ideal holy grail is 12. Never exceed 12. Then I talked about another problem with ESA that's called pure red cell aplasia. So sometimes what happens is, whatever you do, the hemoglobin does not increase. The platelets are normal, WBC are normal, but RBC completely aplastic. There is no RBC cell in the marrow. Reticulocyte also comes down, and it is thought to be because of development of antibody to ESA. So this is a dreadful complication, and it was thought to be because of some preservative in the ESA. Now the incidence has come down, but still it's an important problem, and it's diagnosed by seeing only RBC low, WBC normal, platelets normal, and if you do a bone marrow, there is pure aplasia of all the erythroid series, and you can test for anti-erythropoietin antibodies as well. Luckily, thankfully, we have encountered only 2 or 3 cases. Now, another important problem is the problem of cold chain. So in India, the temperatures are 35, 40, sometimes 45. And what temperature does ESA need? 4 degrees, 2 to 4 degrees centigrade. So sometimes we don't know how the ESA is transported, and our question in our minds is whether we are giving water or is it ESA we are giving, because we just see the syringes, and though they may be cold when they are there in the hospital, but during transport, what temperature exposures have happened, we do not have a clue. In India, we had a similar another drug, that's the polio vaccine, which is again very sensitive to temperature. India could eradicate polio, and this was because the polio vaccine has a cold indicator, temperature indicator. So if the central box is white or lighter chain, lighter color, you can use it. Or otherwise, if it becomes of a different color, do not use. So it was very easy. So in India, the polio vaccine, if it was bad and if the temperature fluctuations were there, it used to become pink. So we used to know when we were giving the polio drops to the child that if it's pink, don't use it, throw it away. However, unfortunately, none of the erythropoietin companies in the world, neither in India nor anywhere in the world, for reasons which can be easily understood, have not taken this up. So what we give is transparent injection. We don't know how much of it is water, whether it's really working or whether the active drug has gone off. So it's very important that cold chain be maintained. So this is one of the challenges in our country. Another important challenge is ESA resistance. Whatever amount of erythropoietin you give, the hemoglobin does not rise. So this is an important thing. And why does it occur? And this is the latest, which has changed the therapy of anemia. Till now, iron and erythropoietin. Now we have certain important things as well. And what is that? That has come up because of ESA resistance. What is ESA resistance? It can be because of iron deficiency, B12, folate, hemoglobinopathy, hemolysis. So any of the factors. So this is not very serious because you can identify and correct it. The problem is ESA resistance can occur because of two things: inflammation in CKD and HIF pathway. So CKD is an inflammatory state. You have all the cytokines, the bad cytokines. Bad cytokines are all interleukins, tumor necrosis factor, TGF beta. All these are bad cytokines. Good cytokines are IL-10, 13, and 4. These three are good cytokines. So in CKD, all the bad cytokines are high, good cytokines are low, and as a result, you have inflammation. Inflammation inhibits the production of erythropoietin. Inflammation also increases the level of hepcidin. Inflammation inhibits the action of erythropoietin. So iron utilization, EPO utilization, everything is disturbed because of inflammation of CKD, and this leads to erythropoietin resistance. The other important thing is emerging role of HIF. What is this HIF? HIF stands for hypoxia inducible factor. So normally whenever there is hypoxia, this factor is produced in the body. And what does it do? It helps in production of erythropoietin from the bone marrow. Apart from that, it helps in iron absorption. It helps in protecting the kidney, and it also helps in preventing mineral bone disease in CKD. Most important thing is this HIF is a good thing. Just remember, don't get confused. HIF is a good thing. Hypoxia inducible factor, as the name shows, whenever there is hypoxia, this gets induced and this increases the production of erythropoietin in a normal person. Now, what happens in a CKD person? So in a normal person, when the oxygen concentration is normal, this hypoxia inducible factor gets degraded and it does not produce EPO. So whenever there is a normal oxygen concentration, whereas whenever in a normal person where there is hypoxia, this HIF factor, it is stabilized and this leads to formation of erythropoietin. So this is very, very important. This happens normally. In CKD, what happens is because the metabolism slows down, there is less consumption of oxygen, and the body feels that there is normoxia, that is pseudo-normoxia. So the end point is in CKD, the HIF factor, which is a good factor, is not produced. And as a result, the erythropoietin, it is not generated, and this leads to anemia of CKD. So with this in mind, a lot of innovations have occurred, and one of the major advances of this decade is drugs which inhibit the degradation of HIF. They are called HIF-PHI inhibitors. So these increase the level of hypoxia inducible factor. They are also called HIF stabilizers. We also call them oral erythropoietin, and they are roxadustat, desidustat, molidustat, vedadustat, and daprodustat. Don't worry about the names. In India, only one is available. Happily, it's become available in Indian market 6 months ago. It is our own indigenous drug, that is desidustat, Desi. You can remember desidustat. It's available in India. It's an oral drug, so no problem of cold chain, no problem of injection, no problem of erythropoietin resistance, and it increases the level of HIF, which is very good. And the dose is 50 milligram, 2 tablets on alternate days. And as of now, phase 4 trials are underway. Along with every good thing, we have some bad things as well. Each drug under the sun has some side effects. And one of the major side effects of this drug is it increases the level of VEGF. And VEGF may be related to angiogenesis, increasing diabetic retinopathy, and long-term cancers. So as of now, in the short-term studies, there has been no increase in cancers or no increase in diabetic retinopathy, but they have put a caution that the dose should be seen and we have to closely follow up these patients. But otherwise, they are very safe drugs and may replace the erythropoietin completely. The last management of anemia is blood transfusion. And blood transfusion, we should not use loosely. It should not be based on hemoglobin level, but on symptoms. And in CKD, we restrict the blood transfusion. We give only if the anemia is not responsive to ESA or there is acute blood loss. Especially in CKD, we avoid transfusions because they cause allosensitization. They cause generation of antibodies because many of these patients, when they go for transplant, if they have received blood transfusions during dialysis or pre-dialysis, they are more prone to rejections because they develop antibodies. So blood transfusion is a no-no in CKD as far as possible unless the patient has life-threatening anemia. Why anemia treatment is important? Because it's not only correction of hemoglobin, it improves the quality of life, it improves appetite, immunity, sleep, it prevents the progression of CKD, it's beneficial for cardiovascular risk reduction, also helpful in diabetics, also helpful in improving the exercise tolerance. It elevates the mood and helps in better cognition. So the benefits of anemia correction extend beyond just improvement of hemoglobin. Many of the symptoms of chronic kidney disease are because of anemia. We do not realize it. We undertreat anemia. So all of us should aim for a target between 10 to 12 in all CKD patients with anemia. So I end saying that anemia is quite common. We should always evaluate for cause, look for iron deficiency, B12, folic deficiency, check for iron deficiency, give iron if it's an absolute iron deficiency, functional deficiency, you have to treat the cause. That is, maybe the newer drugs will help here. Oral IV, no all your preparations. And when the patient is iron replete, you can give erythropoietin. Too much of good thing is poison. Never overtreat anemia. Never give extra iron nor erythropoietin in super maximal doses. So, ladies and gentlemen, thank you for a very patient hearing. I'll be happy to take any questions.
Thank you, madam, for your patient deliberation, and you've touched each and every aspect of anemia and CKD and beyond as well. So I think thanks should be from our side. And you have a lot of fan following from across Pakistan, across India. Pinky, Dr. Sanjeev Puri from Punjab, Dr. Shashi Khare, all joining me in saying thank you. Lots of questions, madam, coming up for you. From Dr. Shashi Khare, can we give erythropoietin in non-CKD patients with anemia?
So that's a very good question. So most of the studies have been done in CKD patients, and you'll be surprised that in some of the patients of malignancy, oncology, erythropoietin finds a role. But again, in malignancy, it's a double-edged sword in the sense that erythropoietin can cause proliferation of other cell lines as well. So there are certain indications. You cannot give it for any malignancy. You have to check the erythropoietin level also, and there are certain malignancies where it's contraindicated. So now the oncologist only should be the correct person to decide which patients to take for erythropoietin therapy. Now there are some studies about use of erythropoietin in acute kidney injury. This is all about chronic kidney disease, acute kidney injury as well. Studies of use of erythropoietin in non-CKD conditions are only anecdotal. They are not proven, because the whole theory is that you use erythropoietin when there is a deficiency of erythropoietin. In most of the other conditions, there is no deficiency of erythropoietin. Erythropoietin deficiency occurs in CKD because erythropoietin is produced in the kidney from peritubular fibroblasts. So those get damaged in kidney disease only and not in the other diseases. And as a result, most of the other anemias are not erythropoietin deficient. The commonest cause of anemia in our country is iron deficiency anemia. Even in CKD patients, the commonest cause in the Western world is erythropoietin deficiency, whereas in India, the commonest cause is iron deficiency anemia, followed by erythropoietin deficiency.
Thank you, ma'am, for explaining that. And Dr. Girish Kesota, and you will smile actually when you see this comment. Madam, you discriminate against pediatrics. You are telling only adult doses. So now I knew you were going to smile, because Dr. Girish, Dr. Manisha will tell you her background, and then she will answer your question. Her Dr. Girish's question is pediatric dose of erythropoietin. And while you
Okay, so
answer
that's why.
yeah.
So as Dr. Sanjay Kalra said, see, I did my MD pediatrics and then jumped into nephrology, so I don't discriminate. In fact, I'm biased towards the pediatricians, and I really
Girish is
respect
also
them.
smiling.
It's
Girish is
more
also laughing.
difficult to handle. It's more difficult to handle children than adults. So I respect the pediatricians, in fact. So and that's why all my doses are in international units per kg. So roughly, rule of the thumb, 25 to 50 international units per kg. And you have to give, again, I mean, you can start with twice a week or thrice a week if you are using conventional. As I said, 3 are there. Conventional erythropoietin, that is cheapest. So you can start with conventional erythropoietin twice a week, 25 to 50 international units per kg. If you are using dabipoietin, you have to give it weekly. And if you are using Sera, you have to use it monthly. So they can be used in children as well as in adults. Only problem is that erythropoietin we get 2,000 units minimum in the vial, pre-filled syringe. Children, even 2,000 is more. So we end up giving only half of the vial and we have to dispose of the remaining. Now, a few companies are manufacturing 1,000 units of erythropoietin as well. So suppose if it's a 10 kg baby, then you need to give 500. So even that 1,000 unit half goes waste. So those are certain challenges in pediatrics. But pediatric nephrology is also coming up in a big way, and companies are now focusing on getting smaller vials of erythropoietin as well.
And Dr. Anshul Singhai, Daksab is a diabetologist from Bhilai in Chhattisgarh. He says, ma'am, if we start erythropoietin, will it continue lifelong?
So as I said, continue till the hemoglobin is 12. Even for CKD patients, once the hemoglobin touches 12, which may happen in 1 month, 2 months, 3 months, whatever, if it touches 12, stop the erythropoietin, right? You should not keep on giving lifelong. There is no such rule. Anemia correction by erythropoietin is good, but overcorrection is bad. You will end up with the patient having a cardiovascular event, either a stroke or a coronary artery disease, which we definitely don't want. And it causes faster progression of CKD because it makes the blood viscous. The blood doesn't flow, leads to thrombosis. So in such cases, you will have adverse outcomes. So maintain 12. When again the hemoglobin goes down, you can again reinitiate it. So like you keep on changing your dose of insulin for sugar, same thing goes for erythropoietin as well. And the other thing is, like, as I said, you should be on the lookout for other cause of anemia. So generally, if the anemia is because of erythropoietin deficiency, it is normochromic, normocytic. So that's why we were checking the RBC indices. If the anemia is microcytic, hypochromic, that doesn't occur in erythropoietin deficiency. That's a feature of iron deficiency. So you have to correct that. And if it is macrocytic, it's a feature of B12 deficiency. So you have to correct that. So erythropoietin is not the holy grail for all types of anemia. It works for CKD anemia. Be on the lookout if the patient doesn't seem to be responding to erythropoietin. As I said, look for the other causes, B12, iron, all those things. And if you have corrected everything and still the patient is not responding to erythropoietin, then as I said, that is one of the limitations of iron and erythropoietin therapy, inflammation and HIF pathway. They are new concepts, inflammation and HIF. HIF has come into focus after Nobel Prize winning discovery by Peter Ratcliffe in 2019, where they have focused on hypoxia role and hypoxia inducible factor. And these drugs have come subsequently after that. So if you are giving erythropoietin, you are giving iron, you are doing everything right, still the patient's hemoglobin is not improving, a switch to these HIF PHIs may be on cards. So HIF PHIs have come into the Indian market just 4-5 months ago, and phase 4 trials are going on. But they are very good drugs. And if they are really as effective as the trials show, they may completely replace the erythropoietin and change the face of anemia treatment in the world.
But ma'am, we will still have to give iron along with that, right? To ensure iron sufficiency.
Yes. So as I said, see, HIF, they are very good molecules because what they do is they improve the iron utilization as well. So what happens is, like in inflammation, I told you that whatever amount of iron we are giving, that's not absorbed and all that. So HIF stabilizers, one good thing they do is they reduce the level of hepcidin also. That hepcidin is a bad molecule, that lock. So they open the lock as well. So you still need iron. Your question is very right, but the quantity of iron required goes down substantially.
And Dr. Anshul has another question. You mentioned that a single serum creatinine value is not enough to diagnose CKD.
Absolutely.
So, this case, proteinuria 5 grams per day, serum creatinine 5.3, EGFR 13. With a single value, you can assume it is CKD, or can it be acute kidney injury, acute and chronic also?
It can be acute also. See, CKD means chronic. Chronic means at least 3 months duration should be there for us to know that it is irreversible. Now, the example what he gave, proteinuria 5 gram and creatinine of 5, typically occurs after a dose of NSAIDs. So nephrotoxic NSAIDs, they present with characteristically renal failure with nephrotic proteinuria. That can occur after a single dose and it may be reversible. So you don't call it CKD. But suppose that picture persists for 3 months, then you can call it CKD. Now, if you want to diagnose CKD, which is that condition when you can diagnose CKD with a single value, suppose you have contracted kidneys. Normal kidney size in adults is 9 centimeters. So if you have small kidneys, that definitely shows that kidney is not going to enlarge again. So that is CKD. So if you have that finding on the first ultrasound when you see the patient and the kidney size is small, directly you can label the patient as CKD, but not depending on creatinine or protein.
And Dr. Singh adds to this. He says, Madam, continuing with this, the same patient has got bilateral diabetic retinopathy and uncontrolled diabetes as well. So
Okay.
this would also then go in favor of CKD. Can I go? But still, I'm sure
No.
it might be acute on chronic also.
Absolutely, absolutely. So remember that as a nephrologist, as a physician, always are on making the diagnosis of acute on CKD. If you say CKD gone, ESRD, nothing more to do. So the thing is, always try to rule out acute. Even a patient of diabetic nephropathy who has a creatinine, maybe creatinine of 2, and suppose baseline proteinuria of 2 gram, he may again suddenly have a creatinine going up to 5 because he developed some NSAID induced injury, or he had some dehydration or accelerated hypertension. So these are all acute factors. So acute factors are defined by those factors which completely reverse within 3 months period. Okay. So if in a diabetic patient also, if the patient is having a creatinine of 2 and you have a report which shows a creatinine of 2 3 months ago, then you can call this patient as CKD. But with a single report of diabetic patient with diabetic retinopathy, even if retinopathy is there, it's not necessary that all retinopathy patients will go into CKD. So with a single report of creatinine of 2, you cannot label CKD. Again, you have to wait, even in a patient of diabetes with diabetic retinopathy, for a report of 2 after 3 months. All right. So 3 months duration is mandatory to define it as CKD.
CKD. One question let me take. This is from Dr. Vinay Desai. So he describes a 59-year-old gentleman overweight with very poor control. Here, Dr. Vinay, we are giving premixed insulin twice a day, along with multiple drugs. All of them are fine. But we are also giving repaglinide, which will not make too much of sense. Premixed insulin plus repaglinide. So here the best thing would be to stop repaglinide. It is not working in this patient. Fasting is 345. But you change the Voslin 3070 to 4 doses. You make it basal bolus. Tell the patient for a short period of time, for a few weeks, we will give you 4 doses per day. Total 40 units is not acting at all. So let us make it 50 or 60 units. You give something like 25 units basal and something like 8 units regular 3 times a day. That would make a total of 50. Along with that, we can increase the metformin to maximum 1000 milligram per day because your patient is already overweight. And if there is no UTI, no genital tract infection, we can add SGLT2 inhibitor. If patient can afford, GLP-1 RA would be a good choice. We have oral semaglutide now, but that is 300 rupees per day. Regarding endocrine pituitary adrenal investigation, patient is already on Theranorm and we assume that TSH is normal. The first investigation should be for infection. So take a history from head to toe, any kind of infection. Things that patient may not tell you at first visit would be melanoposthitis. So be soft with the patient while taking a history of that. So the first thing would be to rule out infections. Greetings to you, madam, from Dr. Anil Chaudhary. And one more question, again coming from Billai, is Finrenone, ma'am. What is this molecule now?
Yeah, so Finrenone is a non-steroidal aldosterone antagonist. So we have all heard about aldosterone. The aldosterone is a molecule which causes progression of CKD, fibrosis. It's involved with so many things. So aldosterone antagonist, we all are well familiar with spironolactone. Till now, we were using that. It's one of the very good drugs for management of resistant hypertension. Now, we also know the side effects of spironolactone. Gynecomastia is one of the side effects apart from hyperkalemia and other steroidal side effects because spironolactone is steroidal. Then we have eplerenone, which also was better than spironolactone, but again had some of the side effects. Now this Finrenone. So Finrenone, why it's very important and why this question is being asked to a nephrologist, because Finrenone, it has been shown that it's one of the important drugs which retards the progression of diabetic kidney disease. And this has been proven by Fidelio trial. And similarly, it also prevents heart failure. And this was again proved in diabetic patients by Figaro trial. And then you have a Fidelity trial, which shows overall that it was very good for reducing albuminuria, for stabilizing the GFR, and had cardiovascular benefits as well. So Dr. Sanjay talked about SGLT2 inhibitors. We all know now the standard of care for a patient with diabetic nephropathy is if the GFR is more than 30, you add SGLT2 inhibitors. And if the patient is not tolerant to SGLT2, you add GLP-1 receptor agonists. Both are renoprotective as well as cardioprotective. So that's very, very important. And we all know about multiple benefits of SGLT2. Now, even after SGLT2 inhibitors, I mean, the patient is on RAS blockade already. So even after all this, if the patient still continues to have proteinuria, there is some residual risk. What is the next drug to add? Finrenone. So in diabetic kidney patients, we add this drug finrenone, which is very effective in reducing the cardiovascular morbidity, mortality, and stabilizing the kidney disease. So that's a very good drug. And I mean, it's one of the latest entrants in the therapy of diabetic nephropathy. Good point is, we have a trial, Ckd trial, where finrenone is being used for non-diabetic Ckd as well. So like we had for SGLT2, we had Credence trial, and we had the Empiric trial where it was useful in diabetic, and then we had the DAPA CKD where it was proven that it's very effective in non-diabetic kidney disease as well. Same thing. So we have this Figaro and Fidelio for diabetic patients, and now we have upcoming Find CKD for non-diabetic patients as well. So the last decade has been very exciting for the nephrologist at least, because we have so many tools in our armamentarium to retard the progression of CKD. And now it's said that an average nephrologist does dialysis, a better nephrologist does transplants, and the best nephrologist prevents everything altogether, prevents CKD, no dialysis, no transplant. So finrenone is one more step in that direction.
Dr. Anshul shares that this patient he was describing, there are 3 to 6 month old reports, creatinine 4 to 5. So now his question is, Madam, how do I counsel this patient? CKD, diabetic kidney disease, creatinine 5, bilateral retinopathy, we assume it is proliferative. Hemoglobin is 7. So his questions are multiple. First of all, how do I counsel the patient? Secondly, is there any chance of the creatinine normalizing? It has always fluctuated between 4 and 5. What is the best case scenario? Can I give finrenone? Can I give a drug known as Nephrosave? Will it have any benefit at all? And all the other drugs also, like Ketoad and all, which are used. And then, one by one, and iron and erythropoietin also in this patient. Hemoglobin 7.
So just remember the 10 commandments. It's easy if we divide them into 10 commandments and remember like that. So the last important aspect, which I'll also tell, is patient counseling. Talk to the patient. So first thing is, what scenario you are describing looks like a CKD only, because if the creatinine has been 4 or 5 and that's been there for 3 months at least, it's a diabetic kidney disease. It's a progressive disease. The GFR keeps on declining in a normal person after the age of 30 by 1 ml per minute per year, whereas in a diabetic patient, it declines by 10 ml per minute per year. So the GFR is going to decline, and he's slowly going to progress to end-stage kidney disease. So you have to tell him about the diet. So we tell them half teaspoon salt per day. All these are important. And oil, half liter per month. That's what we advise them. We advise them, especially with a creatinine of 4, to cut down on juices. And we tell them to take low potassium fruits. That's apple and generally papaya. That's what we tell them to take. And again, like, it's a healthy diet overall. Don't make it too restrictive. Don't stop all the protein. Let the person who is a vegetarian continue protein. Indian protein intake is already low. So we have to give low protein, not no protein diet. So avoid non-veg. They can take egg white can be taken. So remember, 0.8 gram per kg is fine. And 0.8 gram for a 50 kg person, it's around 40 gram of protein, 40 to 50 gram you need to give. So that's the first message. So don't alter the diet too much. Generally, what happens is patient goes to somebody and then they tell, stop this, then what the patient has to eat. So that also you have to remember. If the patient is having edema, then restrict the water, fluid, tea, coffee, everything to 1 liter a day. And you can go up and down from there. If there is no edema, the patient can continue to take water. So in a nutshell, this is something about the diet. That's the first commandment. Then next thing is, if a patient is a diabetic, again, diabetic control, maintain HbA1c around 7. We don't go very strict. And I'm not going to give a lecture on all that, but roughly maintain blood sugars like that. Hypertension, maintain 130/80. Now new target is 120/80. And the order in which you use the drugs is ACE inhibitors, ARBs. But with a creatinine of 4 to 5, we won't be using them. We use ACE ARBs till the GFR falls to 30. After that, if you want to use them, you have to do the potassium very frequently or use them with a diuretic. So if the GFR is okay, we start with ACE or ARBs. The second drug to add is a diuretic. The third drug to add is a calcium channel blocker. Many of the CKD patients, we have to add all these three drugs together, triple combination. The fourth drug to add is aldosterone antagonist if the GFR is more than 30. So again, in that fine CKD trial, we are using a GFR of 25, right? So we cannot use it in this patient. Creatinine 4 or 5, his GFR must be in the stage 5 range, that is below 15. So you cannot use it there. So these are about the anti-hypertensive drugs. Beta blockers are used only if it's a cardiac indication. And still the blood pressure is not controlled. Last we add is clonidine, minoxidil, so on and so forth. So this is the order in which the drugs are used. The RAS blockade, followed by diuretic, followed by calcium channel blocker, followed by aldosterone antagonist in case the GFR is more than 30, and then rest. So that is the third commandment. So we have talked about diet, we have talked about glycemic control, we talked about blood pressure. Never ever combine ACE plus ARB. Remember that. So this is the third commandment. Then fourth, what do you do is look after the anemia. So CKD prescription from a physician, from a postgraduate, from an MBBS, all these 10 things should be there. So you write the anemia management. So iron therapy and erythropoietin therapy, both of them. And as I already explained how you check for that, so maintain a hemoglobin target between 10 to 12 and the transferrin saturation 30 and serum ferritin around 800. Remember that. So this is about anemia. Then the fifth commandment is look at mineral bone metabolism, maintain calcium, phosphorus, vitamin D in normal levels. And if the PTH is high, then you give active vitamin D. Generally, we see bio D3, calci, all those things in common prescriptions, which is wrong. Bio D3 and all are active vitamin D. There's a difference between cholecalciferol and active vitamin D. Cholecalciferol is used for treating vitamin deficiency. You can call it inactive vitamin D, that can be given. But active vitamin D should be given only if the parathormone is high. So it may look too complicated. Leave that therapy to the nephrologist. But that is the fifth commandment, that maintain mineral bone parameters. Then use of statin. It's very, very important. All diabetic CKD patients after the age of 18 add a statin, and all CKD patients after the age of 50 add a statin. It's important, even if the cholesterol is normal, for cardiovascular risk reduction. So that is the next commandment. Then look at uric acid. Uric acid, you treat if the uric acid is very high, more than 9, or if the patient is symptomatic. We see allopurinol or febuxostat, all the prescriptions. In fact, it's not required. Only after uric acid is 9 or 10, you need to add, or if the patient has symptomatic gout. Then next commandment is bicarbonate. Maintain bicarbonate between 22 to 24, and you have bicarbonate preparations available in market. Bicarbonate adding is very important. It retards the progression of chronic kidney disease. So that's the next commandment. What else do we do? In diabetic patients, I already told you, retarding the progression. So SGLT2, then GLP-1RA, and Finrenone, depending on the level of GFR, those things are done. Then next commandment is vaccinate all these patients. So you have to give 4 vaccines: hepatitis B, pneumococcal, influenza vaccine, and varicella. These 4 are important. In India, sadly, adult vaccination is completely neglected. So that's important. Then one more important thing, what the physician needs to do is protect the arm veins. We get all IVs and all that. These patients, fistula is the lifeline, and we don't get any veins to make a fistula. So never ever puncture the veins in the non-dominant arm. If the patient is right-handed, you do whatever blood drawings and all you want to do in the right hand. Preserve the left hand. Left hand, the non-dominant hand, should always be preserved in case the patient goes on dialysis and needs a fistula. So that's important. And the last but not the least commandment is prevent further acute insults. Acute insults means they'll keep on taking all indigenous medicines. Sorry to say, very common but should be avoided. Then NSAIDs, accelerated hypertension, infections, all those things should be looked at. And the question about the ketoad and all that, ketoad or keto alpha, they are all keto analogs. They are good. They are used when the patient is on a very low protein diet, meaning no protein in diet. Then only you add these. The problem is if you give, they are very expensive. If you add 1 tablet TID, it has no meaning. If you are using them, give them in appropriate dose. And what's the appropriate dose? You need 1 tablet for every 5 kg. So for a patient who's 50 kg, how many you need? You need 10. So remember that. So that it's very expensive, and it's indicated only if the patient is on a very low protein diet, not all the time. About NephroSafe, all those things, lesser said the better, no evidence. Sometimes we give them just to pacify the patient or appease the patient that we have given something for CKD. Not harmful, but no signs of benefit either. And lastly, about the probiotics available. Again, there are certain papers that probiotics and prebiotics and a combination of pre-probiotics, they help in removing the urea through the stools. So can be used, not contraindicated, but again, look at the patient's pocket and then use it. You have to complete the other 10 guidelines before you switch on to these measures. So they can be used, not contraindicated, but it should not be that the prescription of a CKD patient contains only a keto ad or a keto alpha and a probiotic and nothing else. Have more focus on the diet, on hypertension, stopping of smoking, walking 30 minutes daily. All these things are important. And last is patient counseling. Tell the patient that, see, maybe what I counsel them is that 80% you can control with your diet, exercise. So focus on the things which are in your hand. 20% is not in your hand. It may be in your genes. I'm not scientifically correct, but I explain to them like that, so they connect with it. They understand positively that 80% is in my hands, and if I follow all these things. And the major thing what I realize is diet is important, correction of anemia is important. Hemoglobin you maintain 7 gram, the kidney disease is going to progress. There is no point in adding keto ad and all 10,000 things and maintaining a hemoglobin of 7 because the patient doesn't have money for iron or erythropoietin. So those things should not be done. So I think this would be my take on management, and give them hope. And I have realized with counseling, 80% of patients, they reach a GFR of even 10 and continue like that. Dialysis should not be started till the patient is symptomatic. There is no cutoff level of creatinine for dialysis. And the latest concept is the ideal study, which says early initiation of dialysis versus late initiation. They found that there was no difference. So you can wait till the patient is symptomatic. And now we depend on the patient also. Patient's opinion should be also taken into account. If the patient doesn't want to go on dialysis, if the creatinine is 6 or 7, you explain to him that 10% risk would be there. But if they are willing to accept no symptoms, you can follow them closely, and they can be on this 10 commandments. And many of them, they pull on through life without going for dialysis. But as a nephrologist, two physicians or two GPs are humble. This thing is that learn to identify CKD early. If you start all these measures early, that will only happen if you do the GFR, which is often not done. So if you are able to identify the patient early and put on these 10 commandments, your prescription should contain all these commandments. Your prescription should contain the GFR of that patient. It is mandatory. Apart from creatinine, urine protein or albumin and GFR should be there. We will go a long way in preventing the progression to dialysis and transplant. A life of dialysis and transplant is very difficult for the patient, very expensive as well, expensive for the country. So again, I come back to my previous statement, a best doctor is the one who prevents the disease rather than treating established disease.
Thank you. And Dr. Anshul also reinforces that statins must be given to everybody with CKD, because CKD is a CAD equivalent. It automatically puts you at high risk of CAD.
Yes.
And
so more than 50 years, CKD statins for everyone. Diabetic CKD more than 18 years. So that's the guideline.
And actually, some of the Western guidelines say you don't even need to do the serum cholesterol in the beginning, even without looking at the cholesterol.
The cholesterol is normal. You are not giving for cholesterol reduction. You are giving for CV risk reduction.
CV risk reduction. Many more questions, and ma'am, many comments and appreciation coming for you from Dr. Anand, from other doctors. But one question from Dr. Vinay Desai: if you can do FCM, that is ferric carboxymaltose in adults, what is the dose? Rough rule of thumb, if you can tell. And how often do I repeat FCM? How often do I repeat the hemoglobin and the iron studies?
So no need to get muddled up with all the formulae and all those things. What you do is get a baseline TSAT and the ferritin level. And if it's low, you can give FCM single dose. It comes in 500 mg. So you can give two 500 mg doses. And good thing is you can give it at a go. So 1000 mg can be given at a go over a period of 15 to 30 minutes without a test dose. So give it slowly. You can give it in the clinic. Be prepared for anaphylaxis. It's never happened so far, but always be prepared. But give it a bit slowly. Don't give it as a push. Safer is to give it over around 15 to 30 minutes. And you can give the whole 1000 mg. And then after you've given, what you can do is you can repeat the iron profile maybe after 3 months or so. That's a practical tip. And if the iron profile goes down, you can again give a second dose. I already told you the formula that the hemoglobin deficit into 2.5 into weight plus 500. If you really want to calculate accurately the iron requirement, but most of us practically don't do it. Roughly, we give 1000 mg, repeat the levels, and see when they are coming down, we again repeat a dose of 1000 mg.
Many more comments coming in. I'll just take one or two questions more, ma'am. It is already past 10 p.m. Dr. Neeta Kocher says target hemoglobin in CKD with thalassemia. I think it will be difficult to reach 11-12, so a single digit higher level should be fine.
Yes.
Dr. Sanjeev Puri says, ma'am, how frequently do you see acute kidney injury and dengue hemorrhagic fever?
Don't ask. AKI is very, very common, and dengue hemorrhagic fever, it's a very, especially in the dengue season, we get a lot of AKI. Even in dengue shock syndrome also, dengue hemorrhagic fever, we get less cases, but dengue shock, yes, and AKI is quite common. And again, the treatment is generally supportive. So tropical AKI is very common in our country, right from malaria to scrub typhus to leptospira to dengue. All are very common, especially because I work in a government teaching hospital, and then all these cases, apart from obstetric AKI, so very common, especially in those seasons.
If FCN is not affordable, we can use iron sucrose as well.
Absolutely, you can. As I already said, iron sucrose can be used. Only thing is, don't try to give 1000 mg of iron sucrose at a go. Divide it into 3-4 doses and give. So safe is 200 mg. If you want to give it in the clinic, give around 200 mg. So iron sucrose, that is the only problem. Test dose is not needed, and anaphylaxis is not common. Only thing is, you cannot give it as a bolus of 1000 mg, unlike FCM. So you can give it. I mean, generally, you can give some people give even up to 300 mg at a single go, some people 500. But as per the guidelines, 200 or 300 at a go is fine. You can again call the patient back. You can give it after 2 days again. So no problem. It's very effective. The iron saturations improve. Only thing is that number of doses you have to split it and give. The 1000 mg you cannot give it at a go.
One question I take, this is from Dr. Meena Ajbani. One good combination would be Gutrite, madam, Dr. Meena, Gutrite, probiotic, prebiotic. And lots of other comments coming from you. Most of the questions, ma'am, you had already answered. It was a very exhaustive talk. And we would like to thank you. One last question, intramuscular iron.
Nowadays, we don't give it. That we used to give Imferon and all that, but there are so many better preparations available now that Imferon has completely gone out of use. We don't use it anymore.
Sucrose iron intravenous and ferric carboxymaltose intravenous. We can choose between them, and I think the choice will basically be decided according to cost.
Yes,
according to cost and
because efficacy is similar. Only thing you need to split that sucrose. It's fine, no problem.
With this, madam, I'd like to thank you on behalf of everybody who is listening. A simple thing, hemoglobin, just such a small molecule. But what you've demonstrated is that you know not only hemoglobin, not only nephrology, but also entire internal medicine. So hats off to you. Turbans off. Thank you, madam. I'd like to thank everybody for having joined in today. Like I said, Sunday evening, there are a million things that you can do. But the fact that we've all chosen to be in this webinar means that we are interested. We want to improve the health of our patients. I would also like to thank Team FDC for supporting us in this endeavor. And I'd like to invite Team FDC now for the vote of thanks and to thank Professor Manisha Sahai once more.
Thank you, ma'am. I think it's one of the best sessions we had in the 4 sessions of Iron Talk, because it was very compact presentation, but a very explanatory proceedings which we have taken during the question answer session, ma'am. And we are really thankful that you've been very patiently handling all the questions and simply have tried to answer all the questions. And thank you very much. Thank you, Dr. Sanjay Kalra. Jai Hind.
Jai Hind.
Thank you, Dr. Sanjay Kalra. Always, you keep on doing these innovative things. So really, a great thank you to you. Thank you. Thanks, FDC.
Now onwards, madam, in our circles, your name will be the Iron Lady now.
I told you it's a dangerous thing. I don't want to be an Iron Lady.
That slide was there.
Yes.
Right. Thank you.
Thank you, ma'am. Thank you very much.
Thank you.
Okay, bye.